So a very good evening once again. On behalf of Walter Bushnell Healthcare Foundation, I extend a very warm welcome to all our distinguished guests to this very special evening. As you're aware, every year we organize a scientific symposium to address the key issues in the field of obs and gynae, along with the IOG Dr. Satyapal Awards and Oration Lecture, which is attended by a galaxy of esteemed national and international faculty. Once again, prior to the 10th IOG Dr. Satyapal Awards and Oration Lecture this year, I am delighted to welcome you all to a one-of-its-kind symposia consisting of 4 scientific sessions with leading national and international luminaries on the most happening topics in the field of obs and gynae. I'd like to inform you all that the entire proceedings of today's scientific session are being broadcast live globally. In fact, many of our well-wishers, both from India and abroad, have already logged in to watch this session. A hearty welcome to all of them as well. I would like to extend a special welcome to Madam Sushma Paul Barlia ji. Mrs. Sushma Paul Barlia is Chairman, APJ Satya and Swaran Group, Chancellor, APJ Satya University, and Chairman, APJ Education, which runs 26 educational institutions across India. Mrs. Sushma Paul Barlia, daughter of late Dr. Satyapal, is a leading entrepreneur, a passionate educationist, a dynamic and innovative leader in the pharmaceutical industry, a champion of gender parity and human values in all that she does, and a dynamic thought leader. Leveraging her twin roles as an industrialist and an educationist, she has been a pioneer in fostering industry-academia linkages at many, many levels. Welcome, ma'am. Now, I would like to welcome Mr. Nishant Barlia. Mr. Nishant Barlia, eldest grandson of Dr. Satyapal and son of Mrs. Sushma Paul Barlia and Mr. Vijay Barlia, is co-promoter APJ Satya and Swaran Group, Pro-Chancellor APJ Satya University, and General Secretary APJ Education. He is an alumnus of Stanford University, USA, and has studied management from Harvard University. He has worked with the group's operations in India, Europe, and the Middle East, and is actively involved with the group's pharmaceutical vertical comprising Martin & Harris, Walter Bushnell, Martin & Harris Laboratories, and ASG Biochem. Welcome, Nishantji. We are also delighted to have with us Mr. Aditya Barlia, grandson of Dr. Satyapal and son of Mrs. Sushma Paul Barlia and Mr. Vijay Barlia. He is co-promoter APJ Satya and Swaran Group, Pro-Chancellor APJ Satya University and Joint Secretary APJ Education. He balances his role in the corporate world with his philanthropic dedication to education. A graduate from Stanford University and an MBA from Harvard Business School, he has to his credit several innovative industrial and educational initiatives, including key operational roles in strategic projects of the APJ Satya and Swaran Group. Mr. Aditya Barlia is an acclaimed artificial intelligence expert sought after by business leaders worldwide. He has been on a global tour of more than 65 cities, teaching CEOs and executives and organizations to optimize their operations and increase productivity with AI. He is on a mission to democratize AI education and empower people through his work with Vajal Institute, wherein 1 million people are being trained on AI. He is one of the esteemed speakers also today. Welcome, Aditya ji. And Dr. Neha Barlia, granddaughter of Dr. Satyapal and daughter of Mrs. Sushma Paul Barlia and Mr. Vijay Barlia, is co-promoter APJ Satya and Swaran Group, Pro-Chancellor APJ Satya University, and Joint Secretary APJ Education. While spending most of her time helping oversee APJ's considerable education efforts, she also serves as a member of the management board across the group's businesses. She is a graduate in economics from Stanford University in the US and holds a PhD in finance and a master's degree in management and banking from the prestigious University of St. Gallen in Switzerland. She's also studied business at Harvard Business School as part of the prestigious OPM program. I'd like to thank her for gracing the event with her kind presence, and thank you and welcome. Let us now extend a warm welcome to Dr. Ricardo Aziz, Professor of Synghynie, Medicine and Healthcare, Organization and Policy, School of Medicine and Public Health, University of Alabama at Birmingham. He is also the past CEO of the American Society for Reproductive Medicine and has come all the way from US to join us. He is the esteemed speaker for the 10th Oration Lecture, Metabolic Syndrome in Women, Unraveling the Complexities and Implementing Effective Strategies of the IOG Dr. Satyapal Award Function, which is being held tomorrow at the same venue at 10:15 a.m. Well, he is accompanied by his better half, Mrs. Stya Aziz. So we welcome both of them, Mr. and Mrs. Aziz. Welcome. Now I'd like to request Mr. Nishant Barlia to come to the podium to give a small introduction of Walter Bushnell and Walter Bushnell Healthcare Foundation. Please.
Thank you for the very warm introduction. Professor Aziz, Madam Barlia, dignitaries, ladies and gentlemen. First of all, I must say it's such a pleasure each year to have the opportunity to have all of your august presence with us. It really matters a lot that you grace us each year. And really to meet old friends, connect with so many old colleagues and associates is really a true pleasure for us. Walter Bushnell, as you know, thanks to your support, has grown by leaps and bounds in the last many decades. So I just take a few minutes just to a little bit share with you where we are today and how hopefully with your support we can do some good things together. As you know, Walter Bushnell is one of India's most well-established companies in pharmaceuticals with over 100-plus-year heritage with us for innovative therapies and evidence-based medicine. We really have a legacy of bringing innovative new therapies, many of it by listening to many of you, your suggestions, your guidances, as to what is not only the protocols of today, but the changing landscape in medicine as such going forward. I'm pleased to share with you that we are now, with your support, 32nd ranked all India. We were in fact 34th ranked last year, so we moved up 2 ranks. And in the last 10 years alone, we have grown from rank 48 very dramatically in terms of our growth across all specialties, in fact. We're in fact considered one of the fastest growing companies. Thank you. Thank you very much. And we are now considered one of the fastest growing companies by many secondary market research data as such. And we really built now what we believe are some of the really marquee brands in our industry, whether it be Trotin, Urospas, Venusmin, Martifa, Uralizer, Potro, or even newer ones like Novogest, Gestinol, Valist, Smartilone, Estrogest, and Yamu. This is really thanks to all your thoughts and your kind words. We've always had a focus on science-led medicine. And I really make it a matter of pride that we really talk a lot internally before we present anything to you about the levels of evidence. Is it a consensus statement? Is it something which has good RCTs? Is it something which is a Cochrane review? We take citations very, very seriously. And I'm also very glad to hear that I think, certainly in India and I think globally, we're one of the few companies which really look at doing a lot of phase 4 studies to build up data around various medical claims. In fact, so much that some of our studies are not only being published in international high impact factor journals, we are also going to see that not only they are being incorporated into Indian guidelines, we are seeing in fact international guidelines, and recently there was one study, even European guidelines, they're picking up as such on our studies and referencing them. I think that's a very good area which we'll be able to do. We have extensive pharmacovigilance, and we've been pioneers in India for doing this. So everybody from the colleague who meets you to the receptionist at our office, to myself, we undergo pharmacovigilance training on a regular basis. And we take that importance of safety and quality very, very seriously throughout our organization. We also have built a very extensive cloud-based reference library with very novel databases. which are able to very quickly research references, find keywords, look at interesting new ways. In fact, I remember one of our colleagues had once shared that one of our very senior faculty needed 125 or 130 references to be very urgently sent across to them. And our team was very quickly, in a matter of hours, able to do so and send it across. And we see that as a strength because if you believe in science, being able to quickly get to the heart of the matter is extremely, extremely important. When it comes to quality of standards, I'm glad to share with you that many of our brands are manufactured in state-of-the-art facilities, especially our hormones, and they're accredited with US FDA, EU, WHO, GMP, various ISO, and even what we call ESG certifications such as ISO 14001. And we have a unified quality system. We don't differentiate between a dual-track system as such, and that's the area which we've been working on. So, for example, the same estrogen which is delivered, what we call to you or to your patient, it's the same estrogen that 2 weeks ago was being shipped to Marseille, next week is being shipped to Dallas. That is the way, what we look at quality. And I think that's the reason, hopefully, you see that clinical impact of your prescription when supporting us. We also, I think, among the top 50 companies, only 3 companies actually, I don't know how much this is known, who have their own distribution infrastructure in the country. Most actually outsource it. So I think only 2 of the top 5, and I think top 50 we're the only 3rd. We have our own branches and warehousing systems across the country. There are 17. In fact, we're in the process of adding another 5. And the reason for this is that we're able to make availability very deep into the markets. We have a network of almost 2,000 wholesalers in what is otherwise a very fragmented pharmacy environment, as you're aware. We reach over 500,000 chemists, and we have coverage today of over 5,200 towns and urban centers and villages. And the team is growing. I can tell you, just last week, we were all together, and we've decided in the next 3 years to actually double our team size. So you'll see that depth, that strength becoming, but most importantly, what it means that your prescription, if prescribed anywhere in the country or wherever we are present, should be honored even in the smallest, remotest towns. And if it is not, please let us know. It is an opportunity for us to make it available. So that's another part of our focus as such. I think one of the most unique areas which we've done, and I know many of our colleagues here are accessing it, is the Clinical Resource Center. And really came from a view because when we had looked at it, we felt that the most important thing we can do as a service is to give time back to you, so you can focus more on the patient. We have a very good team here, what we call at our head office. They are doctors who are from AIIMS, they're pharmacologists who are from Jamia Hamdard, the top institutions in the country. And we can support you. We can support you with literature search. We can support you to make presentation slides. We can support the statistical analysis. We've even supported connecting colleagues with faculty for special cases as such. And we find that our ability to do so and to support only can help us both together do the best for our patients. And that's really what the goal is. So I think, and by the way, we do it across subspecialties. So whether we are in that space, whether we have a product, whether out there, anything in the gynecology therapy area, we are happy to support you in any particular manner. We really believe that's the best way to partner together in the long run. So I think this is perhaps the most exciting journey. It's a very long journey, I have to say, with many stumbles and everything, but I'm happy to share with you that last week alone, we filed 2 of our first patented products for phase 3 studies into the DCGI's office. And we have now a pipeline this year where we make another 5 filings, all what we call new patented innovations of ours. And we were on a pipeline of around 17 as such. And the reason we are doing this is we believe that as we are moving towards a research and innovation ecosystem in our country, the future of our whole ecosystem together for translational medicine or overall health is going to be what we call led by innovation and by research. We now have 3 R&D centers. We had 2 last year. We just starting a 3rd one as well. And in fact, it was pointed out to me very recently that our actually R&D center is at 32 Gurgaon, which is down the road from McKinsey. So with respect to McKinsey colleagues, in the same real estate, they staff management consultants, we staff research scientists. That's the belief that we have. And I think today, hopefully, as we go through this journey, what we call is going through, I can tell you it's not been easy. There's been quite a few stumbles and a few things we're still trying to do. But we really hope that our medium-term vision, which was that majority of our revenue should be from IP protected, patent protected, first time, not only in India, but perhaps in the world innovation, will be realized. Thank you. And I think also I'd like to add, I think among the top 50 companies, we are perhaps the only company which respected innovation. And I mean that because we never did Parafor, patent opposition, what we call patent busting. We were, I think, the only company among the Indian top 50. And I think, more than words, confidentiality to agreements, etc., what you call your track record matters. So we believe, internationally we know we have a lot of partners we're talking to, even domestically as well, many people want to work with us because we respect your innovation, we respect your research. And if you have interesting ideas, interesting thoughts, we are very, very happy to listen to you, partner with you, find ways in which, we can bring good ideas, to the market for the benefit of our patients. Finally, I'd like to say that I'm delighted to share that this event is brought to you by the Walter Bushnell Healthcare Foundation, which is really a vision of a university. And really it came from a place where we wanted to find a way to disseminate science and good scientific thought into the wider population. And the reason for that, and perhaps, COVID and all the interesting things that happened around it reinforced it, is very important to have scientific communication in a wider range. And our idea has always been around this. And with that, we're very delighted to have your presence here today. And thank you, I must say, for your time and for coming all the way. Thank you very much.
Thank you, sir. And now let's begin with the first scientific session of this evening, the future of luteal phase support. I invite on stage the chairpersons of this session, Dr. Saurav Prakash Maiti. He is founder and director of Rashmika Fertility, Golpa, Kolkata, and visiting consultant at AMRI Hospitals, Mukundpur and Bhagirathi Neotia Women and Child Care Center, Kolkata. He is a popular gynecologist in Kolkata and has been practicing since 2008. His areas of interest are gynecological endoscopic surgery, IVF, and ICSI. Welcome, sir. Next is Dr. Jayanta Kumar Gupta. He's highly regarded obs-and-gynae with over 40 years of experience and practice at Apollo Multispeciality Hospitals, Kolkata. He utilizes his expertise to address various conditions like fibroids, menopause, infertility, adenomyosis, recurrent pregnancy loss, endometriosis, PCOD, pre-implantation genetic diagnosis, and many more. Dr. Jayanta Kumar Gupta, welcome, sir. We have with us Dr. Kabiri Banerjee, Medical Director, Advanced Fertility and Gynecology Center, New Delhi. She is the recipient of IVF Icon of India Award, IMA 2023, and also the International Foxy Achiever Award she received in 2023. She has more than 50 articles published in national and international journals of repute and has many original research works published in the field of ART. Dr. Kabiri Banerjee. Dr. Sudha Prasad is joining us next. She is the Director, Matritva Advanced IVF and Training Center, New Delhi. She is the former professor and head of IVF coordinator, IVF and Reproductive Biology Center, Maulana Azad Medical College, Delhi. She has a teaching experience of more than 40 years, also the past president of Indian Infertility Society. She has more than 65 national and international publications and many chapters in various books and is also a recipient of many prestigious awards. Welcome, ma'am. Next is Dr. Mridubhashini Govindarajan. She is the Clinical Director of Women's Center, Coimbatore, is the former Adjunct Professor, Tamil Nadu, Dr. MGR Medical University, Chennai. She is an active member of ISAR, ASHRE, ASRM, FOXY, IMA, and CII Healthcare Panel, Coimbatore. She has many awards and recognitions to her credit. Recently, she received the Lifetime Achievement Award by Tamil Nadu and Pondicherry Chapter of Indian Society for Assisted Reproduction in 2022. She is a regular invited faculty in CMEs both in India and abroad. Welcome, ma'am. Now, I invite Dr. Nandita Palshetkar. She is an eminent IVF specialist who has been bestowed fellowship from Royal College of Obstetrics and Gynecology. She is currently the medical director of Bloom IVF and heads 7 centers all over India. She is a pioneer in India for many latest techniques and technologies, has delivered 85 orations and more than 900 talks, and authored more than 100 chapters and papers, and edited 25 books, a recipient of many prestigious awards. She is also the organizing chairperson for AICOG 2025, Mumbai. Welcome, ma'am. And now, the speaker of our first session is Dr. Pratap Kumar. The topic for this is the future of luteal phase support. Dr. Pratap Kumar is Head Department of Reproductive Medicine and Surgery at Kasturba Medical College, Manipal Academy of Higher Education. In addition to being a recipient of many prestigious awards, he has more than 300 publications to his credit and has presented more than 1,000 presentations in national and international congresses. He is also the editor of many textbooks and contributed to several chapters. Welcome, sir. Now, let's welcome him, and now I request Dr. Pratap Kumar to begin his presentation, The Future of Luteal Phase Support. Please note that the total duration of presentation is 20 minutes, and the first buzzer would ring at 17 minutes and the second at 19. I'd request you to please adhere to the times. Thank you.
Very good evening. Thank you for the invitation for me to give a talk at this lovely gathering, and respected chairpersons and all my dear friends. The future of luteal phase support is the topic for today. I bring greetings from the University of Manipal from Karnataka State, India. I will take you through what we know, physiology, luteal phase support, why, how and when, standard versus intensive support, fresh transfer of embryos, frozen transfer embryos, and individualized luteal phase support, and finally, the role of support in IUI and natural conception. We all know it's a phase between ovulation and the next menstruation. It is deficient in patients who undergo ovarian stimulation for IVF, that's for sure. The luteal phase support, administration of pharmacological agents aimed at supporting implantation to enhance probability of pregnancy with successful outcome. When we know corpus luteum produces is not only progesterone, it also produces estrogen in a small way. So we know that the corpus luteum, basically the hormonal activity controlled by pulsatile production of LH by anterior pituitary, 3-hourly stimulation of the corpus luteum. The mid-luteal phase is the daily production of progesterone of 25 mg for 24 hours. And estrogen, estradiol, is also being produced by the corpus luteum in a very small way, but both are needed, 0.05 to 0.5 mg in 24 hours. So when you look at the hyperstimulated cycle as shown in the first arc there, inability to maintain normal secretory endometrium to allow normal embryo implantation and growth. When you compare the normal cycle, hyperstimulated cycle has a short luteal phase. That means there is not much of progesterone there. So when you stimulate the ovaries for an IVF cycle, there are supraphysiological levels of steroids, which basically has a negative action on the hypothalamus and pituitary axis. It inhibits luteinizing hormone release and thereby causing luteal phase defect. The loss of pulsatile release of LH from pituitary gland due to downregulation of LH receptors is basically gets disrupted because of agonist or antagonist protocol, excessive levels of estrogen, the replacement of LH surge by the trigger of HCG itself. The corpus luteal dysfunction has been clearly established in assisted reproductive technology. The agonist protocol, what we have a long protocol, definitely has a deep pituitary suppression, deficient LH signaling in the forthcoming luteal phase. An antagonist cycle basically has once again corpus luteal dysfunction, and moreover when we pick up the oocyte or the oocyte pickup, lot of granulosa cells are being removed and they do not have corpus luteum there. So controlled ovarian stimulation and HCG, supraphysiological sex steroid production, suppression of endogenous LH and corpus luteal dysfunction. If you look at the red one, the natural cycle, the green one is cycle with GnRH analog. Look at the blue one, antagonist curve is very fast diminishing progesterone there. So if you look at the red one again there, the left one, the GnRH analog, if you give as a trigger, it is a LH surge after GnRH agonist triggering versus natural cycle. There will be a lot of corpus luteal deficiency in them. Hence, if you give GnRH analog instead of HCG, there is bound to be huge amount of deficiency. Some of us don't even transfer the embryos. Some of us do, but intense progesterone support. So the role of progesterone seems to be the secretory transformation and desvisualization as mentioned earlier. But more important is immunomodulation. Regulation of the blood flow there, and local vasodilatation and of course uterine muscular relaxation, the action of progesterone. So we know that recurrent pregnancy losses will need progesterone, all IVF cycles will need progesterone, and of course if you're using gonadotropins you have to give. Most of you are giving unnecessary progesterone in a clomiphene induced cycle or a letrozole, you don't have to give. Just for induction with tablets, clomiphene and letrozole, there is no need to give progesterone support because you're going to close the implantation window unnecessarily. But if you're using gonadotropins for a stimulation of maybe for IUI and things like that, you have to give because when you give clomiphene and letrozole, it acts on the hypothalamus, anti-estrogenic effect. The gonadotropins acts directly on the ovaries, so you have to give support when using gonadotropins. Definitely, neoangiogenesis is important in the luteal phase because corpus luteal deficiency seems to be the problem in getting pregnancies. So the progesterone is the important issue there. We can also give a little bit of GnRH analog in the luteal phase. You can give HCG, but it's not popular because of ovarian hyperstimulation syndrome. And of course, research, LH says, or ESHRE says 2019, is at the moment is still under the research. Now, we use natural micronized progesterone. You can either give intramuscularly, or you can give vaginal gel, or you can give the tablets. We give 200 milligram 3 times a day. The micronized progesterone can be used. And of course, subcutaneous injection can also be given at the 25 to 100 milligram per day. But oral dydrogesterone seems to be another introduction in the last few years. We give about 20 to 40 milligram per day. It's not 10 milligram. We give 20 milligram twice a day after embryo transfer. But we don't give any more transdermal because if you give transdermal progesterone, the dose matching with corpus luteum production is several orders larger than the estradiol. It requires too large a skin system for practical application, and skin is basically rich in 5-alpha reductase, which inactivates progesterone. Hence, we don't give any more transdermal. Intramuscular, everybody knows, seems to be the old traditional injections, but it's oil-based, and the disadvantage is terribly painful, yet the patients will take because they want pregnancy somehow, but inflammation, sterile abscesses, and of course, non-compliance. Some people get some kind of a breathlessness after that intramuscular because it's been told to be eosinophilic pneumonia, but is rare, but can also be occasionally life-threatening. Subcutaneous is basically cyclodextrin encapsulation. The newer modality, dose is small, 25 milligram per day. I said how the corpus luteum produces 25 milligram per day. So that maybe are just replacing the same. Better bioavailability and lower dose than intramuscular. more comfortable, and of course vaginal progesterone seems to be the most popular with all of us because of first uterine pass effect, minimal side effects, rapid absorption, and disadvantages are also there. Many people have irritation, they do not want to use it sometimes, and if you have such a symptoms, there can some discharge and bleeding can occur, and some of them don't want to put anything at the vagina there. So vaginal versus intramuscular progesterone seems to be a little bit of comparison. When we put intramuscular, the serum progesterone is 7 times higher, but vaginal progesterone endometrial concentration is 8 times higher. So the value of blood levels of progesterone, I don't think it matters because intramuscular gets into the blood and not much into the uterus. But when you give vaginally, it gets into the uterus as well. The fertility sterility ASRM clearly said, luteal phase support for frozen embryo transfer. Does route of progesterone administration make any difference? 300 patients were studied, 500 FET cycles. Overall, cumulative pregnancy rate was 34% per cycle, with no difference in pregnancy rates in those that received intramuscular or vaginal progesterone. Another report, mini report of 2021, Beyond the Uterine First Pass, Optimizing Programmed Frozen Embryo Plantation Transfers, a mini review was done. It has been found that the vaginal progesterone short half-life of 6 to 8 hours, variable absorption, and limited uterine first pass metabolism leads to supraphysiological serum levels. 50% of intramuscular dose is eliminated in 24 hours, 75% in 48 hours, 87% in 72 hours, but helps in maintaining the value there. However, subcutaneous progesterone, the half-life for 17 hours, may require more frequent injections, but may be more convenient. So if you look at all these vaginal capsule, gel, intramuscular, subcutaneously, everything has its own advantages and disadvantages. You choose individualized method to select for the patient as to what and when to give. However, IOG in 2019 clearly said progesterone is recommended definitely for luteal phase support as strong evidence. Any of the previously mentioned administration routes, non-oral, for natural progesterone as luteal phase support can be used, and dydrogesterone is probably recommended for luteal phase support. The special features are high oral bioavailability, but there can be intrahepatic cholestasis. I had few patients, they come with itching, that's a little bit of not comfortable, but very small number. However, no androgenic, no glucocorticoid, and no mineralocorticoid activity. But we know that reduces cytotoxicity of the natural killer cells by blocking degranulation and shift the dominance from Th1 to Th2 cells. But there are side effects like any other medicine, so many are there, but they are very, very small in number. Lotus 1 trial established non-inferiority of oral dydrogesterone versus micronized vaginal progesterone in 2017 publication. The last line should be read. Lotus 1 demonstrated that oral dydrogesterone is efficacious as much as micronized progesterone in a fresh cycle. Once again, Lotus 2 trial, oral dydrogesterone is a viable alternative in 2018 by Greisinger. The last line to be read again. Lotus 2 demonstrated that oral dydrogesterone is as effective as micronized progesterone even in a fresh cycle. HCG is not recommended because there is no improved benefit over progesterone and definitely increasing incidence of ovarian hyperstimulation syndrome. So GnRH analog, there are many by basically single dose of GnRH agonists on the day 6 after oocyte or embryo transfer may be tried but not proved. Multiple regime for sure is not recommended. 2019 IOG said GnRH agonists as a bolus in addition to progesterone for luteal phase support in HCG triggered cycles can only be used in the context of clinical trial, research only, repeated however is the same. But interestingly, comparison of pregnancy rates and antagonist cycle after luteal phase with agonist versus progesterone, a prospective randomized study by Eld et al. Have said 127 cycles studied, The last line, GnRH analog was associated with a higher pregnancy rates, odds ratio of 3.4, 95% confidence interval, and of course compared to vaginal progesterone. Another study by V. Shang et al. Have clearly said, retrospective study of 300 patients, and again, but they said ongoing beneficial effects on ongoing pregnancy rate and live birth were also different. Addition of estrogen is not clear because endogenously estrogen is an enemic produced a little bit. Meta-analysis argued against this practice as being not very favorable, and of course it's not recommended. As per HRA guidelines, the timing when to start progesterone, the starting of progesterone for luteal phase support should be in the window between the evening of oocyte pickup and 3 days post retrieval. So it doesn't matter if it starts on the day of oocyte pickup or the next day, it doesn't really matter. Progesterone for luteal support should be administered at least until the day of pregnancy test. How long to give was a big question mark. Premature timing of progesterone luteal phase support. Initiation did not negatively impact live birth rate. That means you can give any time. So, the luteal phase, how much to give? In India, I'm sure we're giving up to at least 10 weeks of pregnancy. I don't think anybody stops. I'm not very sure. The Europeans and Americans say stop it the day of the HCG report, but we know a little worried about when to stop. So I give up to 7 to 8 or 10 weeks of pregnancy, but most of them, short versus extended progesterone supplementation for luteal phase support, a systematic review and a meta-analysis by Marian et al. There was no significant difference in live birth rate between the patients who discontinued progesterone support at the time of pregnancy test and those who continued little longer. Our patients, when I tell them, they said little worried about it. We have no study on that in India. However, fresh and frozen embryo transfer, there is no benefit of HCG or estradiol to progesterone. An agonist may have a small role on the day 6 of embryo transfer, 1 dose. Of course, everything seems to be arguable. Luteal phase support for women trying to conceive by intrauterine insemination or a natural intercourse. Vaginal progesterone may increase clinical pregnancy rate. However, its effect on miscarriage is uncertain. Uncertain for sure is intramuscular progesterone, etc. But however, neither oral progesterone nor any other medication appears to be associated with any improvement of pregnancy outcome. As I said, a clomiphene and letrozole induced cycle, there is no need to give. You give for gonadotropin only. So finally, which route of progesterone is most effective? Cochrane review found 25 studies comparing different modes of progesterone. No significant difference in terms of live birth, ongoing pregnancy. There is no convincing evidence that one route of progesterone is more effective than the other, although more and better designed trials are needed for sure. We must look at pharmacology of different routes and patient preference. The quality of evidence range from low to very low. To conclude my presentation, we do not know it all with regard to luteal phase support. However, some important clinical questions can be answered with a reasonable degree of certainty. Overall, progesterone appears to equally effective HCG compared to HCG, but we know OHSS is high, and different routes of progesterone have similar efficacy. More patients' preference studies are needed as to the route and preparation of progesterone. More work is needed on luteal phase monitoring, the aim of personalizing luteal support. So what's the future? It's for you to decide. The future of progesterone support has to be argued quite pretty well, and discussion should go on. As always, we find scientific evidence is most important. Thank you once again for your invitation and for the requesting me to give a talk. Thank you so much.
Thank you, Dr. Pratap Kumar. That was a very insightful talk. And I think we all know that individualizing luteal support is also now coming in, and you touched upon it. I think that's really important, doing progesterone levels at different, before starting, whether you want to add, and all of us in this audience are using multiple routes in a patient. that is the practical thing that we are doing in our practices. And I'm glad you touched upon it, that there is no Cochrane review, or there's no firm evidence to say that do this or do that. And even the World Survey actually says that all the physicians are actually, I don't know if anybody on the panel would like to comment on that.
In fact, there has been a Midron study in 2021 that compared only vaginal progesterone and vaginal progesterone with dydrogesterone in frozen embryo transfers. And the pregnancy rates were similar, but the biochemical rate in the one taking dydrogesterone was significantly less. So this was the first study that we are all very skeptical of multiple progesterone use, but this was the first documented study that said that we may use it and it may have a benefit. And that we've started doing that, and though the data is yet to come out.
Thank you, Dr. Pratap Kumar. Thank you for that really enlightening talk.
I have a question. During the luteal phase support, we are using progesterone for the luteal phase support. And in a frozen embryo transfer, we are using estrogen for the growth of endometrium. And how long should we continue this estrogen?
Yeah, that's what I said. The role of estrogen is very limited. And if at all you give it till the beta stage is positive, then you need not continue. But all the literature doesn't say estrogen has to be added along with progesterone.
So we are giving estrogen for endometrial preparation. And after embryo transfer, should we stop estrogen?
No, it's like that, because first of all, there's not much of place at all. But if you give, you can continue with no harm in pregnancy. You can give up to 10 weeks of pregnancy. But I don't continue, because I just stop, because the exact action on the pregnancy is not well understood.
So we stop it practically at between 8 weeks, 7 to 8 weeks. I mean, I continue estrogen till then. Once the beta HCG is positive.
We suggest that we should discontinue after 8 weeks.
Yeah, 8 weeks we stop the estrogen, and between 10 to 12 weeks the progesterone is stopped.
Yes.
Thank you, Dr. Pratap, for your wonderful talk. You have covered the whole aspect of the luteal support. I just want to say a word about it. Years together means more than a decade when I started, and the Crinon gel and the other gel, vaginal gel came. So we started that, but the patients were not comfortable because there was so much of vaginal discharge. And then the dufestrone came, so the dydrogesterone was given orally with the intramuscular progesterone. I am very fond of that, because I cannot rely one drug for the luteal support, because my patients are for years I worked in a government hospital, and my patients were not that well to do to spend so much of money and without pregnancy. So always I have given the two drugs that it has to be covered properly, as now the studies has come that dufestrone is not giving proper finding, proper progesterone level, and something should be added for that. So of course intramuscular is a very painful. So now with the vaginal progesterone and dydrogesterone works very well, I must tell you. This is my experience.
So that's a very interesting finding, ma'am. But over the years, intramuscular progesterone with its huge side effect, I think one of the things that patients avoid IVF is because of the pain of intramuscular progesterone. And if we are able to reduce that, I think it will be a great benefit to our patients. And I'm sure we have each our experience, but we have seen vaginal progesterone with oral dydrogesterone gives equally effective results. However, in those women where there is premature spotting, where the bleeding comes earlier, we have to transfer in an agonist trigger cycle. And in some repeated failures, we are administering intramuscular progesterone. But I'm sure you'd agree that the effort should be to move away from that.
I think it almost seems like every decade the approach changes. When it's, when we understood that we needed to give a luteal phase support early on, it was HCG first, and we had problems with hyperstimulation and OHSS and that type of a thing. Then the intramuscular. Intramuscular was painful, therefore was almost not used in Europe. And it took about a whole decade before Europe found out that if you used only vaginal, a good percentage of them were not getting adequate amount of support. Whereas it was absolutely, intramuscular was banned in Europe for that period of time. And then it became IM, and then now the current thing is the oral one. As far as the patient is concerned, it's probably the best possible way that you can give it. And I think it's fairly, the Lotus studies, I think part of it was done in India as well with some of our experts, and it's been fairly comparable to it. And I don't really mix up too many things. I stick to one thing and do it. And I don't think I've had any problems with using that digostrone.
It was a very nice talk, Dr. Kumar. You did highlight a lot of things. There is still a lot to learn from properly based research, and we all can pull in our experiences and get the best possible solution for the patient. And I think that's all I would like to say for this particular session. Thank you very much. And I thank my colleagues sitting as panelists. Thank you.
Thank you for this very informative and engaging scientific session. I request you to please be with us for a few more seconds. We'd like to present mementos to you, and I request Nishant Barlia ji to kindly do the honors and present mementos as a mark of our respect and token of our appreciation to all the respected chairpersons. Dr. Pratap Kumar, Dr. Nandita Palshetkar, Dr. M. Govindarajan, Dr. Sudha Prasad is here. Okay. Dr. M. Govindarajan, Dr. Sudha Prasad, Dr. Kabiri Banerjee, Dr. Jayant Kumar Gupta, and Dr. Prakash Mehri. Thank you all once again. The second scientific session of today's evening is Antibiotic Stewardship in Obs and Gynae Practice. And I invite on stage the chairpersons of this session. We're just putting their nameplates. I think I can start introducing them now. Dr. Ritu Khanna. She is a Director, Khanna Medical Center Fertility Clinic, Varanasi. Her areas of interest are laparoscopic and hysteroscopic fertility-enhancing surgeries, color Doppler, 3D, 4D ultrasounds, IVF, ICSI. She is a recipient of many prestigious awards, including the Dr. B.C. Roy Memorial Award for Outstanding Contribution in the Field of Gynae, Presidential Award 2021 by IMA Banaras for exemplary good work and services in field of gynecology. She has presented and published many papers on male and female infertility and holds many important organizational positions. Welcome, ma'am. Next, I call upon Dr. Ashok Kumar. He is the Director, Professor of and Head, Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. He is the Vice Chair-elect for ICOG 2024 and President, Delhi Society, AOGD 24-25. He is the editorial member of Indian Journal of Medical Research and Archives of Gynecology and Obstetrics. Welcome, sir. Dr. Malvika Sabharwal is requested to kindly join us. She is the Chief Department of Gynae, Laparoscopic and Endoscopic Surgery, Jeevanmala and Apollo Spectra Hospital. She is the recipient of many distinguished awards, such as Dr. APJ Abdul Kalam's Excellence Award, and was conferred Padma Shri by the President of India. She is the organizing chairperson for many endoscopic workshops and conferences, and holds many important positions in various scientific committees. Welcome, ma'am. I'd like to invite Dr. Anita Singh. She's a well-known name in the field of gynecology. She is ex-professor, Patna Medical College, and presently the chief consultant at JP Hospital and Jan Chikitsa Hospital, Patna. Her areas of interest are high-risk pregnancy and endoscopic surgery. She is the president of Association of Obs and Gynae of Bihar and Jharkhand. Welcome, ma'am. Let me call on stage Dr. Narendra Malhotra. Dr. Malhotra is the Managing Director of Global Rainbow Healthcare Agra and the Director of ART Rainbow IVF Agra and Delhi, with special interest in high-risk obstetrics, ultrasound, laparoscopy, and infertility, ART, and genetics. He is the past president of ISAR, ISPAT, IFUMB, FOXY, AOGS, and recipient of many awards and recognitions. He is associated with many eminent societies and healthcare bodies. He has presented many papers, lectures, and has to his credit innumerable publications in distinguished journals. Welcome, sir. And now I have the pleasure of introducing the speaker of this session, Dr. Mala Srivastava. She will be speaking on antibiotic stewardship in Obs and Gynae practice. Dr. Mala Srivastava is a renowned doctor practicing at Sir Gangaram Hospital, New Delhi. She is the head of Gynae Oncology Unit and also Gynae Endoscopy and Robotic Surgeon. She is Vice President of ISOPARB 2324 and past president of AOGD 2021. Her areas of specialization are high-risk pregnancies and endoscopic surgeries. She is one of the few surgeons in India who excels in the field of robotic and minimally invasive gynecology. She is the recipient of APJ Abdul Kalam Excellence Award and Dr. Subhash Mukhopadhyay Women's Health Icon Award. Dr. Srivastava. I now request Dr. Srivastava to begin her session, requesting you to kindly adhere to the timings, ma'am.
Good evening, everyone. I'm going to speak about antibiotic stewardship in obstetrics and gynecological practice. Why we are talking about antimicrobial resistance? Because the world is concerned about it. AMR is one of the top global public health and development threats. Recent years, AMR contributed to 4.95 million deaths worldwide. There is misuse, overuse of antimicrobials in humans, and it affects almost the entire world. And of course, we have to understand it's a great risk for modern medicine. It puts lots of things into trouble because we are seeing in our day-to-day practice that most of the common antibiotics that we are using, the bacteria are becoming resistant to it. So when we have treatment, problems are there in surgery, sections, cancer chemotherapy, and world faces an antibiotic pipeline and access crisis. There is inadequate research and poor development of pipeline matter of concern. So what about Indian scenario? There is 2,97,000 deaths attributed to antimicrobial resistance and more than 1 crore deaths associated with antimicrobial resistance. And India has the 144th highest age standardized mortality rate by 1 crore population associated with AMR across 204 countries. So we have to see from this chart, the commonest death is due to cardiovascular disease, chronic respiratory disease, but antimicrobial resistance is one of the important cause of morbidity and mortality of the patients. There are 5 pathogens which we have to be aware. E. coli, Klebsiella pneumoniae, Staph aureus, Acinetobacter baumannii, and Mycobacterium tuberculosis. All these are becoming very quickly resistant to the common antimicrobials that is available. So why we have to prioritize? We have to prevent all infections. Are we preventing inappropriate use of antibiotics? Ensuring universal access to quality diagnosis, appropriate treatment of infection, and of course we have to tell our patients, we have to give antibiotics only when it is necessary. Most of our patients are taking over-the-counter antibiotics. Once they have symptoms, they take 2 doses or 3 doses of antibiotics and they stop taking the antibiotics. And then again after 1 or 2 months, if they have the same symptom, they repeat the same prescription on their own without coming to the doctor. So it's a population, our patients who are responsible for this antimicrobial resistance. And of course, over-the-counter drugs that our pharmacist friends are giving to the patients. They will not come to the doctor, they will go directly to the chemist and they will take the antibiotics from them. So this is all leading to rising antibiotic resistance, and it is a cause of worry for today's practice. Because very few new antibiotics are being developed. Though we are seeing so much antibiotic resistance, and this is a growing public health emergency which needs to be addressed. So, big pharma institutions have left working for new antibiotics and have started working on drugs for cancer, neuropsychiatric conditions, and endocrine, blood and immune disorders because they are more profitable. And they are not working for newer and newer antibiotic developments. So there is a dry antibiotic pipeline, and rising resistance will definitely have bad impact on patient therapy in the future. So this is the brief glance of new antibiotic launches in the last decades, and they are very few. You can see very few new antibiotics have been launched in last decades. So with so few new antibiotic approvals worldwide in past decade, world will move into phase of antibiotic crisis in upcoming years. See, we had an era when there was no antibiotic, pre-antibiotic era, when we had to combat the infections by our natural immunity. Then came the antibiotic era, and the world was flooded with antibiotics. And we have used antibiotics right, left and center. And now most of the bacteria are developing resistance to those antibiotics. So in the end, we'll have very few antibiotics which will work. So when we have limited resources to run household, we measure each spending judiciously, and the same thought has to come while we are using antibiotics. We have to use our antibiotics very judiciously, only when it is required, only the dose that is required, only the duration that is required. So the future of antibiotics depends on all of us, each and every one of us who is using the antibiotics for our patients. India's confrontation with AMR reached global headlines in 2008 when a new multi-drug resistant strain was discovered in Swedish traveler infected with a common bacterium, that is Klebsiella pneumoniae, and it was named as New Delhi metallo-beta-lactamase, a key moment in the rise of India as a major player in the emergent antimicrobial crisis, the resistant crisis. So Gangaram study finds high levels of superbug, and this was published in 2011, and it created ripples. it has been more than a decade this news had created noise levels, waking up ministries and health bodies. Returning to the Indian context, despite repeated warnings from the WHO, it took nearly a decade for the problem of antimicrobial resistance to be openly addressed politically. Even our Prime Minister, Mr. Modi, in Man Ki Baat 2016, he talked about antimicrobial resistance as a serious crisis, Gambhir Sankat. He also stressed that the Indian population takes the medicine over the counter without consulting doctor, and they will, without issue of appropriate dosage, without listening to taking avoidance without prescription, and finish the course of antibiotic even if they felt better. So what they do, our own patients, they use overuse or misuse of antibiotics. Of course, there is lack of awareness. They do not understand that if they take inappropriate drug for shorter duration, then it raises bacterial resistance to that particular antibiotic. Of course, there is poor infection control, lack of regulation in animal husbandry. Antibiotics are commonly used in animal farming as growth promoters and to prevent disease to the cattle. However, this can lead to antibiotic residues in meat and other animal products. Most of us are using milk and milk products. And this is directly or indirectly transmitted to us without even knowing or being aware of it. And this slowly may cause antibiotic resistance in us. We may be thinking that we are not taking antibiotics judiciously, but this indirect intake of antibiotics through milk and milk products or maybe animal products, this can lead to antibiotic resistance in some of us. Of course, there is limited access to clean water, inadequate surveillance regulation, and of course, there are challenges in the pharmaceutical industry. So what are we trying to do? We want to do a strengthening of regulatory oversight of antibiotic use. We want to invest in healthcare infrastructure, public education. Of course, we have to have a surveillance of antimicrobial resistance. And of course, we have to have a collaboration between the private and public sectors. So they are seeing that Indian studies and review have pointed the existence of inappropriate and unnatural antibiotic in obs and gynae. There is a multiple studies which shows that obstetricians and gynecologists are using antibiotics which are not so necessary without diagnosis, and then we have to think again and again when we are using the antibiotics for our patients. So there is a need of antibiotic stewardship, so that a coordinated use of antibiotic in order to improve patient outcomes, ensure patient safety, and also combat antibiotic resistance. We have to optimize antibiotic use, doses and duration, preventing antibiotic resistance, surveillance and monitoring, education and communication, and policy implementation. Why it is necessary? Because there is a unique physiology of pregnancy. And we have to think of antibiotics, we have to think of risk of maternal and neonatal infections. Fetal safety, antibiotic prophylaxis, prevention of perinatal infections, these are important. And when we are doing of intrapartum antibiotic prophylaxis for group P streptococcus, we have to manage UTIs, minimize antibiotic resistance. Monitoring and surveillance is important. So there are 7 elements of hospital stewardship. We have to have a hospital leadership. In our hospital, almost every month, Dr. Wattal, who is the head of the microbiology department, he sends us a communication with how many antibiotics are we using and what is the result of the hospital drug resistance in our hospital. And that communication between the clinicians as well as the microbiologist is important in all the tertiary care hospitals. So we only have to write a simple and big application, and it is just easy and fast. Implementation is not so easy. We are talking about challenges, we are talking about researches and what to do. we have to have a patient's factors, we have to have empiric judgment, and of course we have to have a source of income for pharmacies in small hospitals. But what are the factors which guide antibiotic selection? We have to first diagnose a condition, think before we prescribe antibiotics to a patient, and of course we have to think about the duration, doses, and everything. So what are the challenges? There are competition among doctors, absence of a champion, utility value of an antibiogram, poor enforcement of regulation, time constraints. So sustainability measurements are there. We have to have a universal antibiotic policy, collective responsibility, incentives, availability of microbiology culture facility, feedback system, and community awareness. And we have miles to go. So best way is to save antibiotic. Each one of us to become responsible stewards in antibiotic use. And we obstetrician gynecologists have to contribute a lot. So if we want, we have to follow the guidelines. What are the guidelines? ICMR guidelines are there, which says, what about UTI in pregnancy? Nitrofurantoin is a category B drug, cefalexin is category B, erythromycin is category B. So we have to think about the ICMR guidelines, which has very nicely proposed which antibiotic to be used. Vaginal delivery, we can use either ampicillin, which is the preferred drug, or if there is an alternative drug, we can use cefazolin, and if allergy, vancomycin can be used. Third or fourth degree perineal tear, single dose cefotoxim or cefotetan. If there is alternative drug, cefazolin 1 gram IV can be given, or single dose amoxicillin clavulanic acid can be given. Preterm labor or premature rupture of membranes, IV ampicillin 2 gram followed by 1 gram, 4 to 6 hourly, or erythromycin can be given. Cesarean delivery, single dose cefazolin, or if allergic, you can give clindamycin and gentamicin. ICMR has given lovely guidelines. Rescue cervical cerclage, ampicillin. Puerperal sepsis, piperacillin tazobactam. Alternative, clindamycin, or ampicillin sulbactam. For hysterectomy, whether abdominal, vaginal, or laparoscopic, cefazolin 2 gram IV single dose, or cefiraxime can be given, and if allergic, you can give clindamycin and gentamicin. Laparoscopic or hysteroscopy, then you can give cefazolin or cefuroxime as an alternative drug. Abortions, azithromycin. Alternative drug is doxycycline. HSG, doxycycline can be used. Pelvic inflammatory disease, preferred is cefixime or metronidazole. Alternative, levofloxacin, ofloxacin, ceftriaxone, and doxycycline. Pelvic inflammatory disease, if it is severe with tubo-ovarian abscesses, cefotetan is the preferred plus doxycycline, but alternative can be sulfaxetine or clindamycin. Vaginal candidiasis, fluconazole is preferred. Alternative can be miconazole or nystatin vaginal tablets. Vaginal candidiasis, fluconazole or alternative can be miconazole. Vaginal trichomoniasis can be secnidazole or tinidazole. Bacterial vaginosis, metronidazole or metronidazole, we know all these things. But most of the time we are using mixture of drugs. So we have to reserve, watch and access. In prescribing antimicrobials, we have to choose the right patient, right time, right dose, right route, right duration. Then and then only we can prevent resistance of a bacteria to the common antibiotics. So what more can be done? To decrease infection, we have to decrease the use of antibiotics. And of course, we have to decrease the morbidity and mortality from antibiotic resistance. So we have to be aware, updated, and of course, we have to have self-education as well as the patient education. We have to keep our eyes open on newer developments. Is there any new antibiotic approved? One must be aware of new antibiotics approval. Treatment of resistant infection is important. We have to broaden treatment options and improve efficacy and safety of the patient's use of antibiotics. So we have to reduce treatment failures. We have to combat emergency threats. And of course, we have to tailor treatments also. So there are new drugs in the practice which is coming. Martyrdom, that is ozenoxin, which is DNA grace inhibitor, DNA topoisomerase IV inhibitor, common indication, gram-positive, MRSA, acne impetigo, levonorgestrel, which is a DNA gyrase inhibitor, of course, MRSA, acute bacterial skin and skin structure infection, ceftazidime and avibactam, non-beta-lactam, beta-lactamase inhibitor, gram-negative complicated urinary tract infections, and biopenem, because this is also beta-lactamase inhibitor for gram-negative and gram-positive aerobic and anaerobic bacteria. And these are given parenteral. So this is martyrdom, which is better drug. And of course, we have to use them very judiciously. We don't want bacterial resistance to them. And with broad spectrum, we are looking forward for better results. We have to liaison with microbiology department. Education and training is important. Patient education is important. And of course, with a concluding remark, antibiotic stewardship in obs and gynae is of paramount importance to ensure optimal patient care while mitigating the risk associated with antibiotic overuse. Adopting and implementing effective stewardship practices, we can improve better care to our patients. We have to preserve antibiotic efficacy. We have to ensure patient safety. We have to prevent complications. Then and then only we can have global health impact. Resource utilization has to be done judiciously, and of course we have to adhere to the guidelines. In essence, antibiotic stewardship in obs and gynae is not just a prudent practice, it is an ethical responsibility of each and every people that we are practicing medicine. By incorporating these principles into daily clinical practice, healthcare professionals contribute to the sustainability of effective antibiotic therapy, safeguarding the health of current and future generation. Through ongoing education, collaboration, adherence to best practice, the field can make a substantial impact in the global fight against antibiotic resistance. Thank you for your patient listening.
Thank you, madam, for beautifully bringing out the concept of resistance, antimicrobial resistance. The super bug, as we call it, these are bacteria, fungi, viruses who develop a speciality to fight against the drug which was made to kill them. And that is what the super bug is. How are we going to tackle this problem? Because this is the major problem which our countries and the developing countries are facing, because of the widespread use of antibiotics, especially by the, let's say, by the non-medical professionals also. The medical officers, the village compounders, nurses who go on, learn from the hospital and start using them for everything. So we need to be, as you said, literate, antibiotic literate. And maybe in the future we could probably be developing a gene which will go into a bacteria, into the bacterial plasmid, introduce this into that body which is showing antibiotic resistance, and let the bugs fight each other. And of course, we must always remember that microbiome, your own microbiome, is your best defense. So if you are going to kill your own bacteria, the good bacteria which you have inside you, the bad bacteria are going to take over. So that is what my thoughts are about the antibiotic resistance. Thank you very much for bringing it out.
Thank you, Dr. Mala, for such a good topic, that is antibiotic stewardship in obstetrics and gynae. And it is a very rarely discussed topic in our specialty. So you have brought upon this important topic and make us once again, careful towards it. And it is not only the responsibility of the clinical practitioners, but also the policy makers, the pharmacists, and the animal husbandry people. There are so many people who have to be involved in this whole process so that we can make it successful in our country and we can prevent from these organisms from becoming resistant to antibiotics and reduce the, just as I saw the data, people dying out of drug-resistant organisms. To reduce that is a real menace that we will have to take up this topic very seriously
and work towards it. Thank you very much for such a good presentation.
Mala, that was an excellent presentation, and I must say the choice of the topic was so good. In fact, when you actually elaborated on the kind of antimicrobial resistance that we are facing globally, it was quite shocking. We do talk about drug resistance and all that, and we have to be careful, etc. And we do have, as clinicians, an ethical responsibility, like you said, that it is all clinicians sitting over here, it's our responsibility not only to give them, prescribe them medicines, but also to make it clear to them that this is, you have to take a full dose and don't cut it short, and why not to go on to the next. The importance of medicine is very, very important, which has to be told to every patient, because they are the ones who are going to be probably spreading it amongst their family members. So that is something extremely important. And also to tell them that any antibiotic that whenever we prescribe should be corroborated with evidence of culture. Like you said, cultures are available today everywhere. And of course, the tendency of all the patients just to go over to the pharmacy and just pick up the medicines, whether it is in the village or even my friends just do it. They would just feel relief by taking for 2 days an antibiotic and they'll just stop. And next time when they have a problem, they just self-treat them, So that's something which should not be encouraged. And the most important thing, like what you said, is very important. If you're working in a hospital, there should be a stewardship which should be in place, and we all should follow the leader, one should say, and it should be periodically being looked into. It's a very, very important thing, considering the kind of the crisis that the whole globe is undergoing. So it was a wonderful topic, Mala, and I must appreciate the kind of you brought out facts so beautifully. Thank you very much.
Good evening, Dr. Mala. You have raised a pertinent issue of antimicrobial resistance and how to tackle this issue. This is an area of concern, especially for developing countries and for us. What are we going to hand over to our future generation? That is the main thing. And we have to be careful about, first is the hospital setting, what is being done in the hospital. In hospitals or in health centers or corporate hospitals or wherever we are treating the indoor patients, it is the antibiotic policy which is very important. ICMR has given a guidance and they have looked into this issue because of the problem which we are facing. But it is a local policy of each center which will definitely going to run the show. And we have seen ICU and ventilator associated drug resistance, antibiotic resistance. And in local center, these microbiology department is a very important department to look into these aspects and prescribe the antibiotic policy. And accordingly, our purchases and everything should be directed into. But that is the system which is lacking in our place. The second issue which is important is from the patient perspective. We are counseling the patient. We are now aware that we have to tell the patient that he or she has to take the medicine for this particular day, for this particular duration. But the problem is at the ground level. There are two issues which we have to address, and I think this is the time probably the cooperation and all the efforts by all of you is needed, that the drug is costly, compliance is the issue, patient goes to the chemist, pharmacy or chemist are the prescriber. All drugs are now over the counter. So very easy to procure the drug, number one. Number two is patient can't afford the antibiotic. The cost is so high. You see, if you stand at the chemist shop for 15 minutes, you will see the patient is first asking the cost and then take home only one dose, because he or she doesn't have that money to buy the drug. So whenever he or she has the money for second dose, that time the patient will come to the chemist and buy the second dose. So how can you expect the compliance, and all these will lead to the drug resistance? So there are multiple factors, social as well as the professional factors which we have to look into. And probably this is the time that government has given a direction that everyone should be looking into this issue. Thank you very much.
Thank you so much. Thank you so much, Dr. Mala, for that fantastic presentation. And I think it was an eye-opener, it was an alert for all of us. We never went into the data that more than 1 crore is attributable to antibiotic resistance. And so I think that this is the right time to stamp down all the antibiotic overuses. And yes, the hospital stewardship programs would be helping us a lot. And I think there should be categorically SOPs to use which antibiotic for which, and that's going to bring, patients change their doctors, I think, because of the recurrence of infections also. And that's just increasing the cost for the adverse effects. So we can bring down the cost, and I think we can bring down the resistance, and also we can bring down the health of our patient and also improve on our microbiome. So thank you so much once again for the same.
The way patients get medicines from chemists, that will be stopped if antibiotics can be given only by prescription of a doctor.
So there is a law already to this effect.
But it's not being
how difficult it is. You can't make the government responsible for looking at every damn thing. So I think we should be looking at that. And the Pharmaceutical Association should be looking at that. That the chemist should not be. See, for running a chemist shop, you have to have a pharmacist. How many chemist shops have a pharmacist? None. They're just on paper with the license taken. So they're actually run by people who are not even 10th class pass or something. And sometimes they're giving the wrong drug. The similar name, so that's given. So that's a major problem which is there. Yes, it's a major problem. So all of us should be looking at it.
Thank you so much for that excellent presentation and very engaging discussion. We have one more question.
Yeah. So I have a small issue.
Yes.
These guidelines, can this be applied pan-India from a big hospital in Delhi to a small hospital in Lakshadweep? Is it possible the same guidelines apply in a village and in Delhi?
So the guideline is there which should be applied.
It's not possible.
It is not applied, that is the problem.
How can you expect a hospital in Delhi with the ICU, with the sterilization and same expectation in say a remote part, 90% of India is rural. These guidelines, I think, are for the urban hospitals.
No, they're antibiotic guidelines in what disease we should be starting with what and what culture and what. So it's an antibiotic guideline, it's not a hospital-based
I'm saying because once you operate in a good setup, you can give one dose of antibiotic. Once you operate in some remote place,
guidelines which can be followed by anybody anywhere, and we all, just like we follow the RCOG guidelines, we are not sitting in America or anywhere, or you just follow the guidelines, and there are ICMR guidelines available to us.
Let me just ask them, how many of you have read the Foxy guidelines on antibiotic or the ICOG guidelines on antibiotic? You are all Foxy members, no? We as presidents every year work out to get these guidelines out. And they are on the website, they are on our site. Rishikesh has worked out 17 guidelines in last year. How many of you read one guideline at least and are following it? Nobody knows. So you want me to come to the village and say, follow this guideline or you will be jailed. The guideline is given to you. Now the responsibility is yours how to follow it or not.
All the hospitals have to take the responsibility, I think, of following the SOPs and to put it there.
We have guidelines. We have 35 guidelines of Foxy on our website. Just go to foxy.org, read all the guidelines. Everything, there's a guideline for premature labor, there's a guideline for cervical cerclage, there's a guideline for progesterone use, there's a guideline for everything is there.
Our own hospital guidelines, which are based on the ICMR guidelines, So, but we should adhere to that, and periodically they should be checked, SOPs should be made. And of course, the practicing physicians are so many, look at the large number. It can be only reminded, reiterated in various forums, I would say. If you have a suggestion, please. Dr. Ashok, you come out with that.
So thank you so much for the deliberations. I request Nishanji once again to please present mementos. Dr. Mala Srivastav, our presenter of this second session. Dr. Narendra Malhotra, Dr. Anita Singh, Dr. Malvika Sabharwal, Dr. Ashok Kumar, and Dr. Ritu Khanna. Thank you. The third scientific session of this evening is Transformation of Healthcare with Artificial Intelligence. The integration of AI technologies continues to evolve, contributing to improved patient outcomes and the overall efficiency of healthcare delivery. Let's take a moment to set up the stage for this session.
ये क्लिकर इधर लगा दे 2 सेकंड दे दो, ये क्लिकर नहीं अपने आप कर लेंगे सब।
So as they are setting up the laptop, let me not waste time. May I invite these chairpersons on stage now. Dr. Rajbala Tiwari. She is Managing Director of Life Care Hospital, Santati Infertility and Test Tube Baby, Indore. Serving in the medical field since last 25 years. She is an expert in managing high-risk pregnancies, infertility and laparoscopic surgery. In addition to holding many important posts, she is also the secretary of ISOPARP 2224. She has participated in many international and national conferences and has held many important organizational positions. Welcome, ma'am. Dr. Dinesh Kansal is also joining us. He is the head of the department and director at BLK Max Super Speciality Hospital. She is the president of Delhi Gynecological Endoscopist Society and IAGE Managing Committee member. She has organized and participated in many national and international workshops, including AAGL, Foxy, SAFOG. She is the recipient of Times of India Excellence Award, Best Video on Hysteroscopy and many other awards. She is the director for laparoscopic surgery training and fellowship programs and has published various articles in books and journals. Welcome, ma'am. Also joining us is Dr. Anju Soni, head of the Department of Obs and Gynae Department at Soni Hospital, Jaipur. She is the President-elect of IMS 2425 and Secretary General IMS 2223 and the Chairperson of the HIV and AIDS Committee of Foxy 2223, recipient of many distinguished awards including the Wonder Women Foxy Award, and her special interests are high-risk pregnancy, gynae critical care, minimal invasive surgery, urogynecology, menopause and yoga. Welcome, ma'am. Next, I invite Dr. Jaideep Malhotra, Managing Director of ART Rainbow IVF. She is the past President, Foxy, ISAR, Aspire, IMS, SAFOMS, ISPAT. She is also the editor-in-chief of SAFOG and SAFOMS journal and many books. She is credited with the first 500 IVF babies of Nepal and first IVF ICSI Tessa twins of Uttar Pradesh. She has more than 500 awards from national and international organizations, including the Foxy Boggs President Felicitation Award 23 and Amar Ujala COVID Warrior Samman 2023. Welcome, ma'am. Joining us also is Dr. Rishikesh Pai, Medical Director of Bloom IVF Group with 11 IVF centers spread across India. He is immediate past president of Foxy, has received 65 awards including FRCOG Fellowship from Royal College of Obs and Gynae, UK. He has delivered over 50 orations, over 700 lectures, edited over 61 books, and contributed over 65 book chapters, published more than 40 research papers, and co-edited 26 GCPR of Foxy. He will be the scientific chair of All India Conference of Foxy to be held in Mumbai in January 2025. Welcome, sir. Oh, let's wish him all happy birthday. Dr. Ricardo Aziz will also be joining us. We are all aware that he is the esteemed speaker of tomorrow's oration lecture. He is an internationally recognized physician, scientist, and executive. His biomedical research focuses on the study of androgen excess disorders in women, having published 11 books and over 500 original peer-reviewed articles, book chapters, and reviews. He is the founder and former executive director, senior executive director of the Androgen Excess and PCOS Society. Welcome, sir. And now I invite on stage the speaker of the session, Mr. Aditya Paul Barlia. He's here with us, a graduate from Stanford University and an MBA from Harvard Business School. He's the co-promoter of APJ Satya and Swaran Group. Okay, so he is ready to go. Over to Mr. Aditya.
Thank you so much. It's a deep pleasure and it's so amazing to see all of you once again to this event which I look forward to every year. What I love is that, you know, everybody here has almost become like family, where we are meeting, working, and I love our technical sessions because I always learn something more. So I'm going to cover something a little bit different than what we usually do, and which is talk about AI in healthcare. Now, here's the thing. Last year, I caught the AI bug, and I went on a now 75-city tour teaching CEOs in classrooms of 70, 80 people how to bring AI into their organizations. The problem with this is every week, every 2 weeks, the entire field of AI changes. So I'm going to show you a couple of things, but you know, pardon me, tomorrow morning this could all be obsolete. So I'm just going to caution you on that. And this is a 8-week course compressed to a 4-week course, compressed to a 14-hour course, compressed to an 11-hour course. And now I've been asked to do this in what, 1 hour, 45 minutes or something. So bear with me as I go fast. And I'll try to cover some of the top topics. How much do I have? 20 minutes. Jeez, 20 minutes. Okay. So let me rush through this as quickly as possible. I'm going to do some setups and everything, and we'll run through the question. The only thing which I'll apologize for is I was hoping to get some proprietary systems, but unfortunately, because of non-disclosure agreements and since this is being streamed on the internet, I am going to use only publicly available tools right now. So you can just imagine how better this would have been had we used some amazing proprietary medical stuff. So let's dive in. Some of the things which I hope to cover very quickly is talking about AI's help and support as a diagnostic assistant, liability protection for doctors, improving delivery efficiencies and costs across the healthcare system. And in India, that's a big concern because of our scale. Imaging and re-diagnostics at scale, and I'll talk about this in a little bit, research support and update, custom treatment plans, patient well-being, and monitoring, counseling, and mental health. Now, healthcare is very broad. Like I said, I could do this in a 3-day course and we still cover the surface. But I want to do live examples. One of the things which I hate is going to AI conferences where they talk about how great AI is, and I say, okay, show me. You know, you can keep talking about it, but what does this actually look like? So I'm going to, now that we have a short amount of time, rush through this fairly quickly. So let me walk you through a couple of things. And what I'm going to do, And again, I apologize, this is a semi-fine-tuned bot, which means it's not proprietary. I'm going to take a case. And this case, which I'm going to start with, is just a very simple one. Now, as of last year, AI bots off-shelf Swan started completing the American med exams. As of a week ago, most of them now get 92, 93% marks. And a seminal study last year, particularly looking at diagnostic cases, found that they were able to beat most medical students. Stanford's done their, Harvard's done their back one, cleanly and amazingly at when it's coming to diagnostics. So let's take a simple one. You can all read this, hopefully. A 32-year-old woman presents to the clinic with a 6-month history of irregular menstrual cycles, 21 to 35 days, difficulty conceiving, acne, hirsutism, recent weight gain, type 2 diabetes, managed with metformin, no previous surgery, no smoke or consume alcohol or drugs, BMI is 31 kgs per meter square. On examination, you note an elevated blood pressure of 135/85, central obesity, several acne lesions on the face, and the upper back pelvic. Ultrasound reveals multiple small cysts on both ovaries. This is obviously our panel. PCOS. Quite an easy one, right? All right, so I'm going to add my prompt on top. And it was wonderful to read this, but let's see. Okay. So we're going to say that he's a researcher in gynecology, help us understand the case. So I'm going to run this. And let's ask the first question. The first question I'm going to ask, what is the most likely diagnostic for this patient, right? And one thing which I love, this is unfortunately in live, is the internet connection. So let's start with the diagnostics. And by the way, don't try this at home. All of you know how irritating it is when patients start using Google. Imagine once they start using this crazy stuff. So it's PCOS, elevated blood pressure to coexist with PCOS. Great. What is the diagnostic criteria? So running through the diagnostic criteria. So far, so good. On the right track. Let's ask for a treatment plan, comprehensive treatment plan with symptoms, desire to conceive. Plan should include lifestyle modifications, pharmacological treatments, and any other therapeutic interventions. Let's try to get a treatment plan done. So lifestyle modification, weight loss and diet, 5 to 10%, low glycemic index, exercise, stress management, yoga, meditation, metformin. Type 2 ovulation-inducing agent, clomiphene citrate is the first-line treatment recommended. Anti-androgens for hysterism, might be thing, other treatment therapy. That are great. Please give a detailed and comprehensive prescription for this patient with correct dosages. So far, so good. Not too bad. I know some of you might disagree, but not too bad. Also got the letrozole in. Okay, let's go forward. 3 months later, the patient returns for a follow-up. She has lost 5% of her body weight and reports a slight improvement in menstrual irregularity. However, she has not conceived and is experiencing gastrointestinal side effects of metformin. Her blood pressure has improved to 128/78. How would you adjust her treatment plan? dose adjustment, slow release formulation or extended release, fertility adjustment, and by the way, this is not medically trained, this is general purpose model. The medically trained ones are even more insane, where they can really go in. Okay, now we could go on and on and on, and fertility specialist referral, all of that. Let's do some fun stuff with this. Great, please. Write up this case in a comprehensive and detailed manner for a top 4 medical journal. Now, while it's doing this, including the abstract and everything else, since I don't have time, I'm going to ask AI to make a Bollywood song on incredible doctors attending the Walter Bushnell Foundation scientific research session. And I ran this earlier. Let's see what it came up with. Generated now, like 2 minutes ago. I'm going to try that with the 80s style dance song. In a room with doctors in white coats, their secrets of knowledge, hiding views of thought, smuggling minds that go in the shots, dancing with the innovators, rocking to the beat of the medical creators. We are unstoppable, no trying to stop at the walls of the shell. Foundation, we've got the right stuff. Not too bad. 5 seconds, 10 seconds. This dropped about a month ago, and I think it's really cool. And okay, so we have an abstract, we have the introduction, case presentation, management outcome, discussion, standard, great. Let's try, and I'm going to steal a prompt which I have existingly. Yeah, okay, let's prepare the slides for the conference. And while it's doing that, let's do some imaging. And so I'm going to do some cool stuff in imaging. I would take time there. So I'm going to ask it for a photograph of an Indian doctor portrayed as a superhero, dramatic manner, dramatic lighting conditions, dynamic composition, surrounded by medical equipment. And since I have a lot of IVF people here, I'm going to ask it for some interiors for IVF centers. So, ultra-realistic photograph of luxury IVF center, styled in elegant manner, balanced light conditions, upscale. And I'm going to put in another one. Let's do a different type of design for an IVF center waiting room, high-rise building, contemporary manner. So while it's building out those, let's go back to our thing, perfect. Okay, so the very simple slides. We would, of course, go back and forth and do this. And what I'm going to do is now ask it to quickly build the slides for me. And so we took that content, asked it to put in slides, and then we're going to ask the system to generate out those slides. And this might take a few more minutes than I'd like to, since I don't have time. There we go. And now it's creating the slides. And it's picking up pictures from, of course, the database. Obviously, you can point it to how you want it.
And to run the introduction. And make some nice ways of doing. It talks about the case. Metabolic health and all. But this is all live, right? I'm doing this with you. While it's creating the diagnostic criteria and all of that, let's go back to where we were on our pictures. And so the first one I thought was very cool. Let's open these out. So these are our superhero doctors. That are very cool. These are our luxury interiors. And this is the other IVF center, which is more contemporary design. And these are all done live, right? So 5 minutes. Imagine if you have unlimited ability to generate this, that, etc. Okay. I have no clue how much time I have left, but let me rush back. Now that we have made our slides, let's look at the slides. Right, so treatment adjustment, side effects, manuals, initial treatment plan, all of the stuff, slides made instantly, pulled in from this. So very, very cool. And I'm going to do a quick diabetes one, since that's always fun. But this is what I love about this one. So let's do a case in diabetes. And we're going to say, you're a medical researcher. Okay, so we're going to do something different this time. Right, so we're going to have this entire, the medical case study, the clinical presentation, the lab test, everything else. But we're going to try something very different. Okay, so what we're going to say, we're going to ask it to read the latest American Clinical Association's diabetes management criteria and standards of care and run this case through their classification system. All right, so what I'm going to go back and I'm going to open this out if I can find my window, which always is hard to find. There we go. Okay, understood, ready? So I'm going to upload this standard of diabetes, put up the file and say, great. Using these standards, please run the classification of the patient and explain everything in great detail. And now it's going to read the entire classification, right? It's about 49 pages, figure out what's the latest system, and then explain how to classify this patient into the guidelines. If I had time, I would ask it to make a clinical protocol, a hospital management system, and we'd go down category by category by category. And of course, this is based on the standards of care from the American Diabetes Association. This is the classification. This is the management we should do. And the diagnostic plans, etc., and such. And just for fun, since we have a few minutes left, so I'm going to show you something really quickly. This is, ready to go. This is the Bajal Institute. This is what we've been spending the last couple of months on, which is dedicated to training about 1 million people on AI. And one of the things what we realized people are not doing is they're using very short prompts, like 10 words and all. So here's the thing, if you're not using at least 450 words for your prompts, you are doing it wrong. But if you don't get inspiration, we have this directory, which can, for every single business, and we are getting the healthcare directory as soon as we can figure out the liability. And we have these brilliant prompts. And so this one I'm going to use, and all of our prompts are about 450 words. Right? So what I'm going to do is use this prompt, I'm just going to copy paste it in, and we're going to ask it as a nutritionist to come up with a Mediterranean diet for diabetes management. And we go back. Diabetes. And it's a huge prompt. Embark on the task, comprehensive 7-day meal plan, grocery list, factor in frequency, provide tips on sustainability. Diabetes. Anyway, so I'll let it run since I don't have time to edit the entire thing out, conclude for monitoring, etc. Right? Yeah, I should went to cardiovascular, I should have cardio, but so then it wants to framework. Now, of course, you can tell it this is an Indian vegetarian patient, and it'll create an Indian vegetarian menu, tailored day to day and day. And so this type of customized treatment plans, customized nutrition plans are now available at a drop of a hat. So how many minutes do I have left? I don't have a... Am I over? You're going to put the timer on me? So grocery lists, cooking methods, and you can go back and forth. Let me get back to some core principles after showing you this, and I'll end after that on questions and everything else. Okay, so a couple of things. One of the big changes what we have is that, in early diagnostics, and we just had the antibiotic question, which I love that session. And I think one of the very interesting parts about it is the time it takes to diagnose viral versus bacterial, right? And in a lot of cases, people use antibiotics as first-line treatments, and being able to change that is there. But here's the problem. Can we see viruses under a microscope? Yes, no. Not under a traditional microscope, right? You can see bacteria and all. But now, thanks to artificial AI imaging, the electron microscopes, this one, I think, costs around 7 to 8 lakh rupees, about 10,000 or so dollars. And the electron microscope can immediately take a blood sample, take pictures of the actual virus or bacteria, and run an AI imaging sequencer to quickly identify it within 2 to 3 hours, whether it is, so virus instantly, and bacteria after 3 hours of expedited culture. And so by this year, we are going to see diagnostic criteria, US FDA and other regulators pending, who are going to be able to take a significant amount of blood, you can't do the pinprick ones, but really be able to mass run them through diagnostics on imaging. And this, by the way, is applicable to existing data and scans. And here's a wonderful Mayo Clinic study where they were able to take old CT scans and using AI methods, be able to get pancreatic cancer diagnosed 36 months before the clinical symptoms, or before a human being could have identified it using the scans. And so what we're seeing is massive in this year, breast cancer, pancreatic cancer, and a whole bunch of early detections pushed back by a couple of years. So instead of reaching stage 2, stage 3, we're going to go to stage 0. Most of this stuff is coming out in the next 3 to 4 months, and I think it's going to completely change. One of the big issues that a country like India faces is that the vast majority of patients go undiagnosed. And they go undiagnosed because they just don't have access to diagnosis. Our wonderful doctors in the field are working with limited facts at extremely fast pace. So if we can bring this cost down and be able to just take existing images, upload it to a nice AI cloud, and immediately get answers, in the first visit or in the visit immediately after, not waiting 1 week or 2 weeks, I think it fundamentally changes how we look at healthcare and treatment. But how is this going to work? The big problem is with AI, the experts, all of you in the room, right? L1s and L2s and AI is L2. This is how it's going to work. You're going to have multiple different AI models. I've shown you one. There are a lot of competing ones, giving you their suggestions and opinions. These hopefully will arrive at the doctor's desk. Now, the doctor, the expert, is going to weigh and balance because many of these models might get it wrong. They might have different suggestions based on how they're trained. On the data, there's a localization involved. The experts decides then what they think is the right call. and then they are the ones who make the right decisions. So as these are going to roll out, this in fact increases expert productivity, doctor productivity, and really puts all of you in the driver's seat, because a lot of the stuff that you had to do, whether it's taking medical notes or writing up prescriptions or analyzing drug-drug interactions, that can be pushed into AI. And then you're the one who actually has a 360 picture and be able to take the very important call. In the US, for example, they're also adding a liability checker. A lot of lawyers and insurance companies want this, just to check for drug-drug interactions, certain laws for insurance plans. And so it once checks back, and it might go to the doctor and say, hey, doc, love your diagnosis, everything is great, but these are some of the liability issues the legal plan or the insurance plan has come up with. Can you change something or just check it once? And so it's usually powerful because it will stop doctors from second guessing themselves. They have somebody who can look through all the legal muck that doesn't apply to a medical practice, but might be part of the hospital guidelines or regulatory that's not necessarily clinical, and sort of that can come in as well. All of this stuff, by the way, is already out. Right? This is not science fiction. I showed you one example of a model. All of this is out. And it's coming in more and more into practice. There is a lot of issues on consistency, whether we can trust these models or not. But since April of last year, things have gotten crazy. And I want to do two things before giving up my time. So one of the things is the thing that dropped about 2 months ago, which is the ability of high-quality audio patient counseling. And so this thing which I'm using speaks in 40 languages. Hindi it can understand and type, it can't speak, but it can choose and switch languages on demand. So I'm just going to do an English one. And this is a customer support counselor at an IVF clinic. And I'm hoping the internet keeps up with me. Oh, come on, internet. Connecting. And second, let me try to get this off this and try again. Connecting. So if this doesn't work, I'll tell you what it's saying, but basically you can have a very complicated conversation in audio with AI real time. And it'll, hi, I'm calling about so my wife and I are unable to conceive. My mother-in-law is driving me crazy. My mother is driving me crazy. They want grandkids. I mean, okay, I know I just called you guys, but how can you help? Let me take someone for the internet. Internet speed. So it's giving me the text, but it's not really coming on the voice yet. It'll come. No. I'll make the video and I'll send it to you all. The connection failed. This is the only risk of doing live demos, is the internet speed messes up and you're like back to the thing. I'll try once more and then I'll move on. I didn't want to show you something really fun. Yeah. So anyway, the difference is I could ramble on as a patient. Right? And the earlier robots wouldn't understand what's this patient rambling on about. These ones now perfectly understand. They're able to give the perfect answer back, and they're able to chat back and forth. Maybe I can show you what they wanted to say but didn't say finally. And I'm going to end on one last funny one. So she understood. Right, and we ran this. And so I'll show you the text version, but this goes voice back and forth. And this will come up hopefully soon. And just for fun, I want to try one cool thing. I'm going to take the prescription from a Bangladeshi doctor, just to be safe. You are an expert pharmacist, since you covered pharmacists, with 15 years of experience understanding doctors' handwriting. Please look at this prescription and give us complete and comprehensive details about it. I'm going to use a small prompt. And as you can see, it's I haven't shown you this. It's a reasonably, doctor-like prescription. But this is a real one from Bangladesh. I picked this up. And it's able to pick up the disease state, the HTN, NDK thing, and of course the medications, and the frequency, and full explanation. So, one nice thing for patients is now they're going to just be taking pictures of these and uploading and saying, what does this really say? But also I think it's a great way to start pushing out, handwriting and all. And I know some of you have moved to computers and all, but I still believe in the pen. I'll close on that. There's a lot more happening. The Walter Bushnell team has asked me, so, the Vajal memberships for people and organizations right now cost about $10,000, where you can take all of these courses online and learn this. I believe the Walter Bushnell, the CRC, the Corporate Research Center, is doing something for all of you, so please contact them. And I think if you can use them, they'll be able to get some of this in your hand very quickly. And I'll stop there. Questions?
Is this on? I have no idea.
Perfect. I think so. Yeah. Good. Thank you. It was fascinating. I have a list of questions here about 6 or 7 deep. So do we have an hour or so to?
Sure. No such thing as time, right? We all can wait a few more minutes for.
I have lots of questions, but I'm going to ask you one, which I'd like you to help me understand. What in the heck is AI? Because I know machine learning, I know these things. Tell me what AI is.
So the best way to learn AI is to understand this joke. Machine learning and computers are in which programming language? In which language?
It depends.
Python, etc. What is the language AI uses? PowerPoint.
PowerPoint.
It's whatever you want to brand it as AI. And I think this is one of the big problems that we see. I make this joke that everybody who was a crypto coin expert a year and a half ago is an AI expert now. And so there's a lot of hype around this. And that's one of the big focus of what we're trying to do is to show you how to use it rather than talk about it in generalities. What I use is something called generative AI, which you can absolutely not trust. Remember that. Which all it's trying to ask, and if I had time, I'd show you how this works. But what's the next word? And nobody expected this to work. Even the people who made it, and I met some of them, didn't know this would work. And April of last year, it suddenly magically worked. And that's why you see everybody now trying to turn all the AI ships towards this new thing. But happy to send you my slides on this, and you can see the course on it.
I still don't know what it is. So that's interesting.
Yeah, I know. So again,
that's the key.
It is a predictive model of what the next word. How does that go from here to giving us clinical guidelines is a leap that I'll need about 15 minutes more to walk you through.
Great, thank you.
Hi. This time the stud volume 7, the new one, the first chapter on AI is written by me and Dr. Nandita and Dr. Reshma. AI in reproductive medicine in the stud, which has just come out. So we have been using AI in our practice for the last 3 years now. Mainly we use it for embryology. So we use it for grading embryos. We use it for grading oocytes.
So these are the vision models which are getting better and better and better.
Right. So of course, my colleague Nandita also uses it a lot to question when she's doing presentations. She's much more adept at it than I am using it. But I feel that the biggest problem at present which we will face in the AI is a lot of explosion of knowledge. So there are a lot of programs, so many EMR systems are there, different embryo grade companies are competing in the market. You have prediction for preterm birth, you have prediction for cancer. So it's very difficult it's going to be difficult to select the program and utilize it because there's an explosion of programs that are available.
And there's a new one every 2 weeks.
Yeah, so the selection is going to be a problem. And the second thing is, we must know the science because we don't know whether AI is telling you the right thing or wrong thing. So you ultimately, suppose AI gives you a presentation on PCOS, how do you know that it is given you the correct presentation? If you keep on asking question to ChatGPT, after some time, ChatGPT goes mad and it starts behaving badly and starts answering you back. Okay, so because it gets irritated, so and then it may give you the wrong answer. So you must have the knowledge to find out whether what ChatGPT is telling you is the right thing or the wrong thing. Okay, so you need the presentation, you need to go to Google again to find out whether ChatGPT, otherwise you'll give a presentation which is totally gone wrong. So you have to have that basic knowledge. So I don't think you can do away with the basic grounding. You have to use it to use your discretion to find out whether AI is giving you the right answer or not. So that is going to be always there. The doubt will always be at the back of your mind. Are you making a big mistake in going in a wrong direction? When we do traditional researching, you go to multiple sites, you read a lot of papers, and then you derive that knowledge, and then you make your presentation. Here some lady there, an electronic babe, is making your presentation for you. You don't know whether she's on the right track or not. So this is the biggest problem with AI.
And this is very important. Is ChatGPT and other large language models generally search engines? Yes or no? No. Where do they get the data from? All over the internet. Do you trust everything you read on the internet? No. If I took one newspaper's name, can I get everybody to agree that you all think this newspaper is the right source of information? Can I get one journal, IOG, apart from IOG, which you can all agree is the #1 source of information? I don't think so, and I think so that's why it's there. So one of the big things that this is the formula which you actually think about. Pick the model, and again, ChatGPT 4 public version isn't fine-tuned towards medicals, but you can take these models and make them perfectly attuned to the latest medical research out of the box, which is what many companies are doing, and I'm seeing a lot of those come out. But you have to put your context. Your context is important. Rural, urban, India, all of that changes, how you see the world. And that's why you need the 450 prompts. A lot of the mistakes that even ChatGPT and all make is because people use one line. Give me a presentation on PCOS. That's not going to help, right? You have to first outline what you want, what's the details, this. The second is data. And as Sir rightly pointed out, you can't trust the data inside these models. Don't. But what you can say is, I want that presentation. Here are the 10 papers that I want you to read. Here are the 2 books and all. Read all of them. And based on that and only that, without going left, right, and center, make that presentation. So for example, since you had some cool thought processes on FOGC guidelines, I uploaded the hysterectomy guidelines for IVF centers in rural, and it's sort of coming out with one by one protocols. But I've told it only use FOGC guidelines. Don't go left, don't go right, don't use the American ones, don't use anything else. Stick to these and basis on that. And so please don't use these willy-nilly. You have to upload the exact data you want. You can't trust it out of the box. And I think the next models coming out, which have a lot of these data systems built in, good connectivity to the various journals, PubMed. They're already here, actually. I've used some of them, but I think they're going to become cheaper and more publicly accessible soon. Don't use that. You get what you pay for.
Before we start,
it costs 3,000 rupees a month. Plus.
I was just saying that before we started this whole session, he was saying, I'm going to give you a lot of sleepless nights. And after I heard you, I thought I can really sleep well because ChatGPT is going to do all my work, all the presentations, and I'll give you a real-time story.
Narendra used to do.
Never. So I'll just tell you, I mean, I edit 2 journals and there are many presentations which I make, and there's always paucity of time. And my secretary, he is really, after me. So one day, I think about 3 days, he was after me that I had to write a editorial for one of the journals. And he got really fed up because I couldn't do it. He said, Madam, I have written something. Can you please have a look at it? And I was absolutely zapped. I said, why and how did you do it? I mean, you're too good. And he said, ma'am, chat GPT. And
yeah, by the way, all those people, suddenly, so I joke, in education institutions, what's the number one way that students get caught using ChatGPT and other AI models? Right? The teacher looks at them and said, you are too stupid to have written this.
True. And I feel that a judicious use of all the technology is something which is really, really important. And human beings are going to be human beings. You can't really match their intelligence. This is all the creation of their intelligence only. But judicious use is very important. And I think the right choice at the right time of the right things is something which is going to take us forward. And yes, we can use it in a most intelligent way. I think sleepless nights again probably can be avoided because a lot of these guidelines can be immediately checked. By the time the patient is sitting, I just Google through. But yes, of course, the right track is very, very important. And that's something which we should be very much looking into. Thank you so much for a fabulous talk.
No, please, one thing which I want to show you, right? So ChatGPT is an AI model. It's one model and it's become famous because they were the first. How many models are competing now against it? You've heard of Google, Microsoft, 5, 10, 20?
5,000.
This is the number as of this morning.
500,000.
And so the boom, and when I started last year, there were about 3,000 to 4,000, and in 1 year it's gone to 500,000. And all of these models are competing on a lot of things, and there are at least 10, 20 models which are dedicated only to into medical writing, medical research, practice, all of these. And you're going to see those come out, I think, in the next 3 to 4 weeks. Become a member of the institute, you'll get updates.
So, excellent presentation. I think everybody was sleeping is awake. And though we all know that AI is definitely very efficient and can analyze lots and lots of data without any problem, but it has its own problems, we all know. It is unable to have any emotions, as we have all seen, unable to have self-repair. Whatever wrong is done is done. And also, we are going to face a lot of job problems with this. And of course, lack of creativity, out-of-box thinking, and ethical consideration. That's the most important thing. Sooner, I think, whosoever has the treatment, the data is going to be there all over. And that is going to cause lots and lots of problems. So that is a very worrisome thing.
By the way, AI has great emotions. Write a poem on the struggles of IVF from the perspective of a mother. It's really good. What I wanted to do, if the internet was working, was to have a chat, a very emotional chat with the customer representative, and you would have seen them very, very on point, understanding emotions, being sympathetic, counseling. As of a few months ago, it's become really good. Again, these things change every 2 weeks. Great at poetry, by the way. Rewrite this poem in the style of Gabbar Singh. Great. Yep. Try it from his perspective. We do. So that's what I'm going around the world. 11-hour class. 11 hours, 0 to 100 on how to start using it, how to bring it into your organization. Or you can just go online. We have the online version coming out in the next 2-3 days. So, like a CME with proper stuff.
Say, Mr. Barlia, change is the constant thing in life, and we must take it as it comes, happily. And I think we are very pleased with Google. Once upon a time, we used to go to library and search through the books shelf by shelf. and when we wrote our thesis. But I think we are very happy that Google is around, YouTube is around, and again, let us welcome ChatGPT with open arms.
Absolutely, please.
It was mesmerizing, insightful talk on AI, and I think we have to use it with responsibility for the patient care, and it is going to have very, very impactful in our patient, particularly in rural area where the multidisciplinary facilities are not available. So it will be going to great help for Indian public.
Yeah, I think that's an incredible point. I think one of the things is that what I love about this technology, obviously you can't trust it right now, but as it gets better and better, and again, you want multiple opinions from different AI models, you have to decide. But certainly in rural areas, which may only have a very overwhelmed GP or an RMP, even at least getting some sort of support, I think would be fantastic. And they still have to be in the pilot seat, right? And that's one of the biggest things I've learned over the last year. The experts are the experts. What AI does really well is empower all the experts to get more information, save time, be more productive. But you can't do it without the experts because AI is not there, and I doubt it's going to be there for many, many years. Oh, question. Yay. Yes, you are the experts and you can sift through the information. Of doctors? So, I can tell you in the APJ education writing, we have already declared 4 months ago that every single student will do everything using AI, or our faculty will do everything using AI, and everybody's going to. It's like going back and saying, don't teach the kids calculators because they'll forget how to do log tables. And, or don't teach them computers because, their handwriting will go bad. But you do need to create safe spaces for them to have the critical knowledge, understanding, skills, behaviors, which have to be saved from AI. And I think that's how it's going to work out. Going to be 15-20% of AI less, then about maybe 40-50% of AI enabled, and then maybe even 20-30% of AI. But I love giving this example. Remember, some of you are older, so you remember, some of them are very young, so I apologize to the younger people here. But how many questions could you do on a math exam when you had to use log tables? Right, in 1 hour, maybe 10 questions, 1.5 hours. Then they give you a calculator. Did the exam become easier or harder? Become harder because now you have to do 50 questions in the same 1.5 hours and think completely different because they say, being able to calculate is no longer a skill. A calculator will do that, or Excel will do that. Now you have to think higher. And so I think the next generation is going to actually be far more pressured in education because, you can write great English. Who cares? So can everybody else now. So they'll have to actually go to the next level, and that's really excites me. And particularly for all of our students who don't have a great school to go to. I mean, all of us are the 1% or the 0.01% in India. You can imagine all across the world, if every single student had a personal tutor who could ask them unlimited knowledge, and that's going to change the world on that.
Wonderful.
Pawachi? The students or AI? No, they'll talk to AI. Yeah, but the problem is there is zero way to find out if somebody used ChatGPT or not. Wait, can I tell you the cheat code on how to cheat in ChatGPT? Please don't tell your kids. Right? 450 word prompt, but you say, here are 3-4 samples of my writing. Do it in the same tone, style, and level of it, and improve by 10%. Then after 1 month, you say, okay, now 10% better. Then after 1 month, 10% better. So the teacher thinks, oh my God, the student is learning so great. And all you're doing is keeping the writing style, tone, and level the same and going up and up and up. So education institutions, including medical education institutions, we're going to have to change how we look at examinations, how we look at project work, how we do that, because this is a new reality. And the quicker we face it, the faster we can transition, because I think next 3 months, 3 billion people will have access to some sort of AI model. Google has launched their in all the phones. Microsoft has launched in all the phones. Samsung, Xiaomi, all in 3 months are going to launch. So we have to face that. And I think the faster we do it and move on, 7 stages of grief, I think that's great. I think we're out of time almost. Last thoughts before I close?
I just think that, it's very important. It's very important for us, especially all of us who are OBGYNs. The first 9 months in utero and the 2 years afterwards are very, very important for the personality and the logic and analysis development of a child. And that is something which we should definitely invest into, otherwise they'll never be able to use any chat GPT also properly. So we must definitely, those skills are very, very important, and all these mobiles, iPads, computers are taking that away from our children. And that's something we should definitely indulge and invest into.
Well, ma'am, thank you so much. I think we end on that. Sure.
Yeah, so what I feel is that the person will make a lot of money in the future, just like we have this organically grown food, right? So, in the future, similarly, you will have human-generated information. That will be the real value. Because everyone else will, right?
Certified human crafted.
Right. This is purely generated by human brain and nothing else. So that will be the, the real, I would say high value kind of information in the future. My daughter is an engineer in US, and I was telling her that you should start a company where you say, okay, this is only human generated.
Logo there.
Wonderful. I think
we're really out of time. Thank you, everybody.
Give him a big hand. Yeah.
The world is getting insane. Well, thank you so much, Aditya ji, for that wonderful, engrossing, interesting. It couldn't have been more interesting. Thank you for that talk, and thanks to all the chairpersons. I request Nishant ji once again to kindly come on stage to present mementos to our chairpersons. Nishant ji, you have to do the honors, present the mementos once again. So we begin with Aditya ji, Mr. Aditya Paul Berlia. Thank you for that invigorating talk, Dr. Ricardo Aziz. Dr. Rishikesh Pai. Dr. Jaideep Malhotra. Dr. Anju Soni. Dr. Dinesh Kansal. Dr. Brajbala Tiwari. Thank you so much. I now invite on stage Dr. J.B. Sharma to present a brief update on late-breaking randomized controlled clinical trial results of Diosmin in AUB, conducted by him at the prestigious All India Institute of Medical Sciences, New Delhi. Dr. Sharma is professor in the Department of Obs and Gynae, All India Institute of Medical Sciences. He has 300 publications in indexed and non-indexed journals, including 150 in peer-reviewed indexed international and national journals. He has presented over 200 papers in various conferences and has also chaired many sessions, also the recipient of many awards and accolades, and is the chief editor of IOG journal. Dr. J.B. Sharma, please.
Yeah. 10 minutes. Yeah. Okay. Thank you. Okay, so I'm sorry, I'm coming between you and the dinner. So my talk will be just 10 minutes, so please be with us. And after the fantastic talks, especially by Aditya Pal Barlia, my talk will be very, very simple. So I'm feeling a bit smaller, no? But I'll try to make it like, fast. So basically, we have done a study on diosmin, vinusmin, and it was a study for efficacy and safety of diosmin with tranexamic acid and mefenamic acid. So in AUB. So you may think, oh, AUB is also a topic, but let me tell you, if someone has got AUB, then definitely she has a lot of problem and she can be really in medical problem, and we have to treat her. And if you can treat it, in fact, one of my most satisfied patients of my life have been those whom I treated for AUB. They were so much anemic, though so much lethargic, that they could hardly do the work. And when I treated them, like they became so bad. One of my patients, actually, I had to do hysterectomy for her. She was 5.8 gram hemoglobin. So I gave her blood transfusion, did hysterectomy, and after that she came to my office with goggles and beautiful sari, and I couldn't recognize her. So, it's really, you can make a lot of difference to them. So this is the basically study which we did at AIIMS. So all of us know about abnormal uterine bleeding, heavy bleeding, frequent of uterine origin, diagnosis of exclusion by Palm-Cohen classification. As per all of you know about Palm-Cohen, polyp, adenomyosis, leiomyoma, malignancy, Cohen, coagulopathy, ovarian dysfunction, endometrium, iatrogenic and not otherwise classified. So basically, it is ovulatory AUB, and this is the bleeding can be because of decreased venous tone, increased capillary fragility, increased capillary permeability, and increased PGE2 secretion. So these are the various treatments which we give them. Non-hormonal are the first treatment, and later on we can give hormonal and ultimately surgical treatment, of course. So in this case, like mefenamic acid traditionally has been used as NSAID, and then we can use tranexamic acid also is popular these days. We can use the combination also. And diosmin, we know it's a pharmacological action, has libotonic action, anti-edema, vasoprotective and anti-inflammatory action. It improves venous tone, decreases the local endometrial prostaglandin, PGE2 F2 ratio, and it improves the lymphatic drainage, capillary fragility, this thing. So these are the all actions of diosmin. It increases the capillary resistance, improved venous tone, decreases PG secretion, so decreased vasodilatation, less blood loss. It improves the lymphatic drainage also. So all those methods which are causing abnormal uterine bleeding, capillary fragility, etc., that is reduced by diosmin or vinusmin. So these are the various studies we have proven the efficacy of other drugs as well as diosmin. So in the present study, basically we took 100 patients in each group, but after a loss to follow-up, we had 92 patients in group where we gave vinusmin 900 mg 5 days prior to expected date. So that means the patient were given 900 mg of diosmin 5 days prior to period, then during the period. So total about like 10 days or so. Other group was given only tranexamic and mefenamic acid, and we then followed these patients up. For about 1.5 years we did the study. After excluding the exclusion criteria, we did the PBAC score on all of them, and detailed history taking menstrual blood loss, ruled out the other this thing, and physical activity, large blood stains. So all of you know about PBAC score. So like we did in this study, and then so these are the results we found. So the group where we used only tranexamic and mefenamic acid, there were 21% reduction in blood loss. But with additional diosmin, we could reduce by -48. So it was 0.02 p-value. Then days of duration also, decrease in amount of blood loss, -82% in diosmin group, and non-diosmin -71%, again 0.03 p-value. And increase in hemoglobin was like 15% in non-diosmin group and 23% in diosmin group, again 0.03 p-value. And PABC score was a significant decrease from -78 in diosmin group, -73 in the non-diosmin group. And these are the other results basically, and there were not significant difference in them, but this last stage was significantly reduced after this. Okay, so the side effects were similar in the two groups. So some patients did have nausea, vomiting, because all the group patients required tranexamic and mefenamic acid. So some amount of side effects were there, but adding diosmin did not increase the side effects in them, because it's a very, very safe drug. So adding flavonoid, diosmin, vinusmin starting 5 days before onset of menses and during the menstrual period, so total 10 days period, along with traditional tranexamic and mefenamic acid for 3 consecutive cycles, so it will be significant improvement in hemoglobin, decrease in PBAC score, and significant reduction in amount and duration of menstrual blood loss without any extra adverse effects. So this paper has been now published in Journal of Midlife Health, which is a PubMed Index journal, and it is in the public domain. And so ultimately, so adding diosmin to the treatment in AUB and menorrhagia improve the treatment outcome. So this is the home. So I mean, we are using Renexamethyl and mefenamic acid. In addition to that, we can add diosmin to these patients. And like one of my patients, she was having bleeding. So I looked into her eyes and said, "Are you having heavy menstrual bleeding?" And this patient, she was so impressed that this doctor can look AUB by looking through the eyes. So they can really be very helpful. So thank you very much. Thank you.
Thank you so much, Dr. J.V. Sharma. Thank you. And now, please join us for cocktail and dinner. It's being served here and also in the adjoining hall. Yes. We have a memento for Dr. J.V. Sharma. Thank you and enjoy the rest of the evening. Bon appetit. See you tomorrow at 10 in the morning. Thank you.
हाँ
Hello.
Namaskar, hello everyone, very good evening ladies and gentlemen, very warm welcome to all the beautiful people out here. आए हुए सभी मुआज़्ज़िज़ मेहमानों का इस प्यारी सी शाम में तहे दिल से बहुत बहुत स्वागत है. This is Nivedita Nanda heartily welcomes you all in this beautiful, mesmerizing and glorious musical evening. जी हाँ, जितने मेहमान आज यहाँ पे मौजूद हैं तहे दिल से तमाम मेहमानों का बहुत बहुत स्वागत है. और पैराडाइज इवेंट्स जिनके जरिए हर साल एक खूबसूरत सी शाम आप सभी के लिए सजाई जाती है, तो इस प्यारी सी शाम को हम आगाज करेंगे और लेकर के चलेंगे एक बेहद खूबसूरत म्यूजिकल सफर की ओर. आप सभी मेहमानों को बहुत ही खूबसूरत नंबर करेंगे आप सबके नजर. हुजूर तुमको सितारों में ले चलूं, दिल झूम जाए ऐसी बहारों में ले चलूं.
कैसा लगा? ब्यूटीफुल तो आप हैं, आप भी बहुत अच्छी हैं.
हुजूर तुमको सितारों में ले चलूं, दिल झूम जाए ऐसी बहारों में ले चलूं.
उसके